Good to go, Kelly?
Let's go.
All right. Welcome, everyone, to our first Innovation Week, where we try to match researchers, clinicians, and physicians with potential development, both on the business and the technology side. We're here with Dr. Yan from CVIS and really everywhere else on RPI Rensselaer's campus for our first presentation. So that being said, we will defer to you, sir. Good luck.
All right, thank you, Brandon Caddy, for organizing this and for the nice introduction. So today I'm going to present our project on the AI-guided prostate cancer biopsy system. Prostate cancer is a very common disease. Every 1 in 7 men in the United States will develop prostate cancer in his lifetime. Prostate cancer is diagnosed through the biopsy. Basically, the clinicians, urologists, they're going to insert a special needle into the prostate gland of the patient and take the sample from the gland and send to the pathology lab for diagnosis. Typically, each procedure will take 12 cores or more from the prostate for diagnosis. So the global market can be of the prostate cancer. Prostate biopsy can be divided into 3 regions, roughly: the United States, Europe, and the rest of the world. Basically, each part takes like a third of the pie. For the US alone, we have more than 2 million biopsies performed each year, which is a 1.8 billion market with the annual growth rate of 11%. So the current state-of-the-art technology for biopsy guidance is through the fusion-guided biopsy. For example, using the EM is an electromagnetic tracking system to track the ultrasound probe, and then fuse with MR images to guide the biopsy. Before joining the RPI in 2017, I worked for Philips Research for 7 years. There, I, together with my clinical collaborators, developed this commercial system, which is called Euronav by Philips. So here are my collaborators, Dr. Brad Wood and Dr. Peter Pinto. So they are at NIH. So the system actually has been commercialized, and compared with ultrasound-only guidance, it can increase the cancer detection rate by 30%. However, nowadays, after several years, less than 20% of the procedures performed using the fusion technology, mainly because of the procedure cost. By using this external tracking system, you increase the system cost, increase the setup time, make the procedure a little longer. Time means money for the clinicians. And also, it requires a special training. Not all the urologists these days they can perform this procedure. They need to understand what a fusion is. They need to understand how to actually maneuver the system to guide them to further biopsy. If they don't do it well, the system doesn't do anything for them. So the vast majority of the patients do not benefit from this technology. So our solution here at RPI is to use AI-based image fusion without external tracking system. So that actually lower the cost, reduce the requirement on the training, and also to reduce the health disparities to help more patients. The project is funded by NIH through the Trailblazer Award under NIBIB. So here's an overview of our technology. We do the during the procedure, scan the prostate, reconstruct the 3D ultrasound volume using AI, and then using AI again to register, align the MR volume and ultrasound volume, and to fuse them together to guide the procedure. Here's a demo that we have the ultrasound from the ultrasound frames from the scanner and fuse with MRI. If we label target there, we will be able to see how far away the current ultrasound frame from the target, and actually whether the biopsy needle gun can aim at that biopsy target. On the right side is a software interface that we are developing right now. So we want you, that's why I'm here. We want an energetic entrepreneur with a passion in healthcare and medical devices. For more information, you can visit our research lab through that link, or maybe scan this QR code. Thank you.
Fantastic, thank you. I feel like you've done this before in 5 minutes or less.
I follow the instructions, so yeah, did a little bit practice.
Well, since it's just us, and you're the first to go, so thank you. Maybe we take this in two parts to add a little more context for people that are going to be watching this after the fact.
Yeah.
One is on the team building side, and you signed up both on the entrepreneurial and the technology engineering side as well. So I'll ask you questions on what you're looking for either side to maybe cast a wider net for those who are interested. And then maybe some follow-up questions on the technology itself.
Sure.
So let's stay on this slide because I feel it's appropriate. Let's start with the entrepreneurship side. What are you looking in terms of team building? What type of expertise, drive, or initiative are you looking to work with as a researcher?
So yeah, we have a very strong technical expertise, so many publications in the past decade on the technical side, and also together with our clinical collaborators. And also because of my previous work experience, I know many people in the industry and also the clinical clinicians. But I need actually somebody here to drive this commercialization, right? Because I'm a full-time employee at RPI. I can spend time work on this, but I can't be full-time to do this, right? This actually is quite a demanding job, right? To commercialize technology, to make it into a product, and go through the FDA regulation, etc. It takes a lot of efforts, right, to do this. I need somebody actually who is energetic, who has passion in commercialization to help me.
Yeah, it's actually what you just explained is the reason why we're doing this process right here because of the time commitment, especially those on the clinician position or research side. And I don't think people really understand how much time is involved to actually bring something to market. So we appreciate you saying that. We're going to try to build teams around your concept. But have there been other entrepreneurial endeavors before based off this technology that you've learned from that maybe you can offer a little more context on what worked or what didn't?
So last year, one of my graduate students and myself, we went through the regional NSF ICOR program. So we learned quite a bit from there, the value proposition, this end user analysis, etc. So that's why you see some of the elements here. That's what we learned through the process. Yeah, that's basically there. And on the tech transfer side, we filed a couple of patent applications already, and yeah, we are in discussion with the tech transfer office to see what we can do together to help commercialize the technology.
Since you went through the ICOR program, customer discovery, what was some of the feedback that you learned through that program?
Well, that's a very good question. So we actually got to talk to 9 or 10 urologists throughout the country, from East Coast to West Coast, the top clinicians from Stanford, from Michigan, and also the New York City, etc. So the overall feedback is very positive. But I have to say that actually it's biased because it's through my academic connections. So all those clinicians, they're associated with academic centers, like university hospitals. So they actually have this research interest, right? They have been exposed to this before. They want to actually do the state-of-the-art technology. But on the other hand, I actually talked to just a couple of community urologists. We find out, well, they actually have a completely different view. They care about the patient throughput. They care about the how fast they can go through this because they have so many patients lined up there. For example, I talked to one urologist who just recently started his own practice at Orlando. There are so many older patients there who need to actually be in line for several months to get to see him and then to get the biopsy, etc. So I think actually, if we can improve the workflow, compared to the previous technology and shorten the procedure time, that would be actually another breakthrough for the commercialization.
Yeah, I think we described there too, or other dimensions of your value prop that I think on the entrepreneurial business side people can latch on to take that to the next level. So that's good. That's good feedback. Moving on to the tech side, we do have collaborators within your department as well on the ME side to give students a potential team building opportunities for students, staff, researchers. How far are you looking to drive this technology? What's the next step in terms of the iteration process?
So yeah, I think that we need to get this done like a more in parallel. One way we're looking at this to find the students here. We can maybe go through another round of ICOR program and move into the national program this time for the more comprehensive customer discovery and to formally define the business plan, etc. On the other hand, I'm also trying to get in touch with the people already started their own business, right? To see whether I can start the business and get the other venture capital investment, etc., to move it forward. So I'm looking at both directions for now.
Yeah, as the way the course experience is constructed in the spring on the life sciences entrepreneurship side, we're basically folding in all those components within the experience. So approaching this in parallel is really, again, one of the reasons why we devised the concept like this to ensure, because it needs to. It sounds like you realize that as well through some early stage processes.
Yeah, cool.
Can you go back one slide or maybe two slides, please?
Mm-hmm.
One more, please. Yes, this one. So let's say if I were a student within the BME program or just another researcher, which step in this process do you think needs more attention to take the concepts to the next level?
Well, I think actually this last stage here, the let me see if I can bring out my laser pointer. This part, right? We need actually to have the frame to volume fusion display there because that's the view during the procedure. The clinician gonna look at and use that view to guide there to approach the target, biopsy target. So if we can actually do the better visualization, smoother fusion there, and also to validate the accuracy to make sure that meets the clinical needs, that will be the critical step.
Got it. Yeah, I think that perspective is interesting for those that will watch this after the fact, as they try to match up not only their ambition, but where you need the most help. I think that's important because I see this overview and I think it makes so much sense and there's a lot to digest. But if you're iterating a product, what's that next step? And I think where you stand right now, that should be exciting to students. Last question. It's been on my mind for the last 3 weeks since you submitted it. Why 30%?
30% of
detection.
Oh, detection. Oh, okay, that part. Okay, right. You're talking about this number of 30%. This actually compared with the ultrasound only guided procedure because the ultrasound, the problem with ultrasound is that it in the ultrasound image frame you can see the prostate contour, right? But you don't see what's inside the prostate, where maybe the lesion. So that's why we call it a systematic biopsy, blind biopsy. Basically, the clinicians just randomly sample 12 cores from the prostate gland and don't know where to target because they cannot see any potential targets there. So the MR images, they provide a nice view of the prostate and also can point out potential lesions. By fusing this MRI images with ultrasound, you can during the intra-procedure ultrasound, you can see where the potential target is, and you can do the target biopsy. Look at your target, insert needle gun there, and retrieve the small tissue sample. So by doing this target, you basically enable the physicians to see the potential lesion, so they can get better. That's why they can increase the detection rate by 30%.
Have you found what the I'd say the ratio is in terms of the pure number, pure number of potential early detection cases would be? I see that 30%. What would that equate to?
Yeah, that's a very good question. To answer that, I think we need to walk one step back to understand how the prostate cancer screening is performed. So usually it starts from the family physician. For men over a certain age, maybe 45, 50 years old, they will actually start the digital exam and also do the PSA, which is a prostate-specific agent, this kind of a blood test, right? By doing this too, if they feel anything abnormal, because they will gonna during the digital exam, if they feel the prostate, some part is hard, right? Normal prostate will feel like this part is kind of soft, right? But with the potential lesion there, you're gonna feel like a knuckle, right? It's much harder. So by touching that, you feel that, and if the PSA level is high, especially can be increasing, that's another indication. For these patients, they will be referred to your urologist for diagnosis, which is to do the biopsy. So for that population, we talk about the detection rate. Right? That's typically around 30-40%. But using this fusion technology, you can increase that to like 60-70%.
I think that's the answer I was getting at, but you walk us through the process. It makes a lot of sense, especially with testing and training data, getting the ML and AI concept. So this has been great. Kelly, do you have any questions?
Professor Yang, I just wanted to clarify that is this IP being built on top of the original IP that you established at the NIH, or is this working in conjunction with it?
Well, this is actually a different technology. If we call this fusion technology you're seeing right now is the first generation, we are actually inventing the second generation of fusion technology without using this external tracking system, by using AI directly looking at the images and bringing the images together. There's some correlation between these IPs, but it's independently developed here, funded by NIH.
Great, thank you.
Great. In terms of next steps, October 17th, students have an opportunity to match you either on the entrepreneurship, life sciences entrepreneurship side, or the BME side as well. We connect with our colleagues over there who are probably 2 doors down from you in the building. But this is exciting. Again, thanks for going first and presenting. And let's try to build a team on both sides as this goes.
Sounds great. Thank you so much.
Great. Thank you.
All right. Take care.
It may go a long way. What we'll do here, it's 1 o'clock. I'll do a short introduction, Adam, because we'll edit it down and post it. So, stock intro, outro. Go through your presentation, and then we'll ask a couple of pointed questions if no one else is here, just to add more context, because this will be watched, recorded as well. So whenever you're ready, let us know.
Wait, so are the people going to be in the call, or how does that work?
Potentially. We just don't have to opt in, but we're going to record so they can watch it. I know the NME folks are requiring their 70 capstone students to watch all of them. So it allows us to ask questions with just more ample context if they can't show up either because it's a class, other commitment, etc.
Mm-hmm. Okay, yeah. So we can start then. You want me to start? Or
I'll do a quick intro. Kelly, we good?
We're good.
Okay. Welcome. Second presentation at Innovation Week here at Rensselaer, bringing the Capital Region and some others together to try to build out their invention, whether on the innovation or entrepreneurship side. Joining us now is Dr. Adam Ryason from Intelligent Medicine. You have the floor, sir.
great. Thank you very much, Brett. Good afternoon, everyone. My name is Adam Ryason. I am the CEO and founder of Intelligent Medicine. We are a startup here in the capital region. Healthcare facility response to COVID-19 pandemic has fallen short of accurately predicting and planning for infectious diseases due to unaccounted for variables such as ventilation, filtration, building design, and user behavior. Currently, they cannot predict with great accuracy how viral particles spread in each facility as a combined effect of these variables. These issues are compounded by low efficiency mechanical ventilation system within facilities and buildings not adequate for handling existing occupancy loads. What facilities need is a solution that would simulate high risk of infectious scenarios before an individual is at risk. This solution would also provide mechanical ventilation in buildings designed to increase patient quality of care. And lastly, it must adapt to constantly changing environments as occupancy rates fluctuate or when infection rates peak within a given environment in order to provide optimal mitigation strategies, thereby reducing airborne infectious transmission. The solution that I'm presenting to you is Circulate. Circulate will reduce infectious spread by providing health and safety stakeholders better designed facilities and mitigation procedures through viral particle simulation of populated indoor environments. Our solution is a digital twin that utilizes multi-scale physics calculations to simulate expected population behavior. The algorithms within Circulate provide a means to simulate interactions such as contamination spread and fluid flow when analyzed under dynamic conditions. Where no method currently exists for realistically simulating interaction between fluid flow and human behavior, we provide a solution that can analyze and optimize facility design and protocols to aid healthcare professionals. Our team is ran hybrid throughout of Schenectady, New York. We were recently awarded a National Science Foundation Phase 1 SBIR, in addition to an Innovate 518 shovel-ready funding awarded to us by New York State. In addition to that, we have partners such as Siemens, as well as architecture and engineering firms that we work with collaboratively when implementing and developing for hospital systems. Our asks today are for a technical development and a business development team member. The technical development team member could vary from a programmer that is looking to integrate, that is looking to work on the front end or back end of our platform, as shown here. In addition to that, we're also looking for people working on the biomedical side of things to help integrate, help work on the public health and epidemiology side when tying in the results from the simulation to actionable insights that hospitals and healthcare systems can take. In addition to that, either type of team member would be working on different types of scenarios for stress testing our cloud-based simulation and testing out other things that our customers may be looking to do in the future. For the business development team member, they would be actively engaging in customer discovery by going out, performing customer discovery on their own, also sitting in meetings with existing customers and potential new customers to take notes and understand that customers' needs and desires for what their bottom line is. On top of that, they would be working on business model developing and adapting to a ever-changing market in order to adapt our solution to what the current customer and market needs at that time. Thank you very much, and if there are any questions, please feel free to reach out to me. My email is linked here down below.
Great, thanks. You're 10 seconds over the 5-minute mark, but we're not going to hold it.
Wow, that was impressive.
This is fantastic. Again, thanks for submitting a concept to try to build out your team. What we're going to do is we'll ask you some pointed questions, mostly on the team development side. Maybe add a little more context for those that couldn't make the presentation today that are watching this via replay. First, we'll focus on because you're looking to build a team out both on the business development side and the technical development side, which is great. We're looking to cast a real wide net for you. But on the business development side, just for, I guess, a shameless plug for the Life Sciences Entrepreneurship course that's running spring 2023, we're building high core capability into that course so that customer piece actually
Yep.
it dovetails exactly what you're looking for, which is great. Also understanding customer segments, marketing segments, et cetera, they're going to be introduced to that as well as part of the practicum. But I'm going to ask you a time frame because spring 2023, at the end of it, April, May, I'll be making a presentation in conjunction with you and what you're looking for. How much on the business development side, time-wise, would you expect to be accomplished by, let's say, beginning of Q2 of 2023? Because you're iterating on this. This is real. You're tracking investment, but you're looking to take this to the next level. Can you just give us a time frame on what you think or where you need to be business-wise by then?
Yeah, I think pretty much by that time, while we're applying for other sources of funding through conventional funding, through investors, as well as business-related grants, realistically, I see this member being able to contribute to the market segment sizing. So being able to do the research involved with finding out how large this market really is. Not only the market that we're looking at for the next 1 to 2 years, but also the larger scale market of digital twin technology in buildings over the 5-year period. Digital twins is a newer technology that doesn't really have a established growth yet, where we're seeing we're projecting a lot of growth, but we don't know what that growth is going to be like. And so this team member will be able to really do the research into other companies as well as into other adoption rates for some of these healthcare facilities and see what we could project to realistically expect over the next 2 to 5 years.
So just to clarify, by the time April 2023 rolls around, we're looking at 7 months, but really the core of it is during what is the equivalent of spring semester in the academic year. This is just a larger effort to understand where the market is right now and where it could be, correct?
Yes. Yep.
And what I like about that too is that you're looking long view in terms of digital twin potential in other markets. What are some of the markets that you're finding right now that can use your technology?
Yeah, so in addition to healthcare, other ones that we've been seeing are in plants and factories, as well as in the public sector, such as K through 12 buildings, K through 12 schools, as well as public government buildings. So a big emphasis has been put on biocommercialization inside of places such as New York State, where they're looking to retrofit older buildings or bring some of their buildings up to date. And so this technology could really be utilized in any type of facility. And the big goal that we would like to get out of this market analysis is to see which of those segments we would want to go towards next.
Right. Moving over to the technical side, the engineering side, not only with potential BME students, but a larger net as well, ITWS, and really anybody in the campus community. What's the next step? I want to talk about the front end and back end in a second, but in terms of your core technology, what's the next step in terms of perfecting that because of its ML/AI capabilities?
Yeah, so some of the big things that we are starting to experiment now is the input of other data sources. So what we're doing with some of these facilities is we're collecting sensor-based data, whether it's occupancy tracking or it's air AEQ or air environment quality sensing, and being able to better understand how a facility is responding or how the air quality is impacted by the occupancy rates within those places. And the big goal that we're going to be looking to do is being able to tie in a given occupancy rate and behavior to a specific air indoor environment air quality in order to better address what changes that facility should be taking in order to improve their air quality and reduce infectious spread.
So now moving on to the front end, back end development side, that I think is fascinating simply because it's taking an existing technology and now making it a UX UI experience, which is exciting on a number of levels. Where do you expect that technology to be by the end of April? Or maybe not expect, but where would you like it to be?
Yeah, I think pretty much the big part that we could see, depending on if the individual is interested more in the front end or the back end, the back end side of things, they could really be working a lot on these data integration. So pretty much if we have an API, and if we're able to take that API and we can call it from if we were able to call the API from the sensors and be able to integrate that into our front end, that would be a big step forward. On top of that is pretty much taking feedback from our customers and being able to adapt our existing visualizations or help come up with new visualizations that will help better drive those insights. What we want to be able to do is help our customers understand the actionable insights that we're providing them through this data visualization.
Can you do me a favor? Can you just scroll back to one of the first establishing slides where you had the visual of the technology at work? Was it the classroom? Yeah, the classroom one as well. I think that's new. I haven't seen that one.
Yeah.
Or here.
Yeah, so this is a pretty much a waiting room in another healthcare facility, and then right after this, it goes into the classroom. So this is a classroom demo that we've been testing out and experimenting with. Right now, we do have it with the particles as well, just not shown in this specific video. But pretty much what we're doing is we're testing out different user behaviors in each of these different spaces, and then looking at how the spread takes place within those.
So if you were building out your team and there were interested parties to develop this further, would they have the ability to do so?
Yeah. Mm-hmm. Yep, they would pretty much be able to go in and test out different cases that they want to see, different user behaviors, different buildings and facilities, pretty much really robustly test out that platform to see, all right, what are some of the corner cases, what can it handle, what can't it handle, and then trying to see what areas there can be improvements upon based on what our customers need.
Kelly, any questions?
Just a comment. I think it's important for the business development team member or potential team member to understand that they won't be starting from zero in the customer discovery section, that you've done significant customer discovery work and will be able to bring them up to par, day one.
Yeah, that's a great point, Kelly. Thank you. Actually, in addition to the NSF Phase 1 SBIR, we also were part of the NSF National I-Corp. So to this date, pretty much me and the rest of my team have conducted over 100 interviews. We're using multiple different tools for keeping track of these things. We're utilizing tools such as HubSpot to pretty much keep track of different potential customers and how potential customers can turn into leads, and then pretty much keeping track of all of our interview notes through there. So pretty much part of that customer discovery is taking a look at the customers that we have interviewed and then being able to come up with who to interview next based on those initial discussions.
Right. So in terms of next steps, we leave this open until October 17th. The form is out. You build your team at October 17th rolls around. We share the names of the interested parties on both sides. Mm-hmm. And then we have about a week or so to build your team. So looking forward.
Wonderful.
I think our major objective is to help you build a team. So
of course. Yeah, that'd be great. I look forward to it. I think it'd be a really great experience for us.
Thank you, Dr. Ryason. Appreciate it. Have a great day.
Thank you. You too.
Thanks, Adam.